In this video, I will explain what are hypersensitivity reactions, its four types, and their characteristics. And then I'm going to give you so many examples of which you will have a hard time finding ones I haven't mentioned. Hypersensitivity reactions are immune reactions in which the damage caused by inflammation to the self-tissues exceeds the desirable, either because of excessive responses to foreign antigens or failure of self-tolerance, i.e., when trying to kill a fly with a missile causes casualties. You see, some degree of damage to your local tissues is almost inevitable when the body is trying to fight off a pathogen, a parasite or a cancerous cell, for example. This is acceptable if the collateral damage is proportional to the threat posed by the invading cell or organism. This is not acceptable when the threat is minimal or non-existent and yet your organism launches a full attack against it, causing unnecessary casualties amongst your tissues. This is what happens in an allergy. This is also not acceptable when your organism mistargets an innocent cell or tissue and starts damaging it for no reason at all. This is what happens in autoimmune disease. Thus, hypersensitivity reactions are uncontrolled or excessive immune reactions. They are involved in allergies, autoimmune diseases, and rejection of grafts, and can be classified according to their major effect or mechanism of tissue injury, that is, based on how they damage the patient's tissues. Four types exist, numbered 1 to 4. Type 1 hypersensitivity is mediated by IgE immunoglobulins. Type 2 hypersensitivity is mediated by IgM and IgG immunoglobulins. Type 3 hypersensitivity is mediated by IgM and IgG immune complexes. And type 4 hypersensitivity is mediated by immune cells. So, once more, in types 1 and 2, we have immunoglobulins, aka antibodies, as an effector mechanism causing damage to tissue. In type 1, this immunoglobulin is IgE, and in type 2, they are IgM and IgG. In type 3, we have immune complexes causing the damage, and in type 4, we have cells causing the damage. If you can memorize this, you already know the most important thing about hypersensitivity reactions, and you can answer more than half the questions on this topic. Now, for the other half. You will most likely be asked to recognize which type or types of hypersensitivity are involved in each autoimmune disease, as well as in pathological processes such as allergy and transplant rejection. You probably already know most of them. If you know anything about post-streptococcal glomerulonephritis, it's probably that it's caused by deposition of immune complexes in the kidney. Now, you only need to recognize that hypersensitivity reactions caused by immune complex deposition are classified as type 3, and that therefore post-streptococcal glomerulonephritis is an example of a type 3 hypersensitivity reaction. On the other hand, when we talk about autoimmune hemolytic anemia, we are talking the red blood cell membrane proteins causing hemolysis. Red blood cells are circulating in the blood, so it will be very hard for anything to deposit on them. This can only be caused thus by immunoglobulins. Since we are talking about the blood and not in mucosa, for example, these immunoglobulins are not IgA. And IgE is not known for coating the membrane of foreign cells, but rather for its interaction with mast cells. Thus, autoimmune hemolytic anemia is mediated by IgM or IgG, and so an example of type 2 hypersensitivity. Specifically, cytotoxic type 2 hypersensitivity, because the red blood cells are being lyse destroyed. Because you may remember that Graves' disease, an autoimmune cause of hyperthyroidism, is caused by autoantibodies against the thyroid stimulating hormone receptor on the thyroid cells. Maybe when you learned about Graves' disease, you were confused. If the autoantibodies are targeting follicular cells, Shouldn't the cells be destroyed and the thyroid hormone production be decreased instead of increased? But the antibodies or immunoglobulins here are non-cytotoxic. Rather than causing opsonization and phagocytosing of the follicular cells or activating complement, they bind to the TSH receptor in a way that stimulates it, causing the cell to increase hormone production. So, Graves' disease is an example of non-cytotoxic type 2 hypersensitivity. It's still mediated by IgM and IgG, but the cell doesn't die. Type 1 hypersensitivity, on the other hand, is allergy or atopy. This is the pathological description of the allergy mechanism. When you have your first exposure to an allergen, your immune system will mount a primary response. And eventually, the Th2 cells will induce B cells to class switch and start producing IgE against the allergen. All the immunoglobulin E produced will then bind to the Fc receptor on the surface of our mast cells, coating them. When a second contact with the allergen occurs, the cross-linking of IgE molecules will cause the mast cells to degranulate and cause inflammation. Because from the second exposure onwards, the mast cells are already coated by the preformed IgE molecules, degranulation will be virtually immediate once the allergens enter your body and come into contact with the mast cells within minutes. Thus, why type 1 hypersensitivity reaction is also known as immediate hypersensitivity. If you want to go deeper, you will notice that not all the chemical mediators of inflammation in allergy are stored in granules. Some need to be produced from arachidonic acid. This is why, even in immediate hypersensitivity, we will also have a late phase after a few hours. If something involves IgE causing edema, bronchoconstriction, hives, it probably is a type 1 hypersensitivity reaction. Pretty much all allergies and atopic reactions, from allergic rhinitis and food allergies to anaphylaxis, are examples of type 1 hypersensitivity. But please don't label contact dermatitis as a type 1. Contact dermatitis is different. Type 1 hypersensitivity is also known as immediate hypersensitivity. Contact dermatitis is not immediate. It takes time. It's a delayed response. A response mediated by T cells, not IgE. Contact dermatitis is instead an example of delayed hypersensitivity, T cell mediated or type 4 hypersensitivity. Other examples of type 4 hypersensitivity include rheumatoid arthritis, Hashimoto thyroiditis, type 1 diabetes, celiac disease, multiple sclerosis, and Crohn's disease. I hate to say it, but if you don't know the hypersensitivity type and you can't remember the disease's mechanism, type 4 is probably the guess most likely to be right. But hold on there. We have antibodies in diseases such as rheumatoid arthritis and celiac disease. Yes, we do, but they are not the most important mechanism of damage. Rather, they are well known primarily due to their role in diagnosis. And besides, the same disease can cause damage to different tissues through different mechanisms. Post-streptococcal glomerulonephritis, as we said, is caused by the deposition of immune complexes in the glomerular basement membrane, causing inflammation, and is therefore a type 3 immune complex mediated hypersensitive reaction. But acute rheumatic fever is caused by antibody cross-reactivity with myocardial cells. The antibodies against the streptococcal cell wall end up binding to heart and joint cells. And if we are talking about antibodies attacking cells, we are talking about IgM or IgG immunoglobulins, and this is a type 2 hypersensitive reaction. An even better example is systemic lupus erythematosus. In SLE, all the classical manifestations are caused by immune complex deposition in tissues. The malar butterfly rash is caused by immune complex deposition in the face. The arthritis is caused by immune complex deposition in the joints. Nephritis is caused by immune complex deposition in the kidneys. If someone asks you the predominant type of hypersensitivity in SLE, answer type 3. But, as we said, deposits don't easily accumulate on circulating blood cells. So, if someone asks you what's the hypersensitivity type at play in hemolysis in a lupus patient, answer type 2. And in drug-induced lupus, the predominant hypersensitivity is type 2. The same logic that applies to red blood cells can also be extended to platelets. Just as autoimmune hemolytic anemia is type 2 hypersensitivity, in which antibodies are targeting red blood cell membrane proteins, autoimmune thrombocytopenic purpura is type 2 hypersensitivity, in which antibodies are targeting platelet membrane proteins. And if you're wondering, it changes nothing if the red blood cells are not yours or if the immunoglobulins are not yours. ABO incompatibility transfusion reactions, a type of hyperacute graft rejection for a non-solid graft, is also a type 2 hypersensitivity. Antibodies against a self-antigen or antibodies against ABO glycoproteins, they are still antibodies nevertheless. The fact that red blood cells here are not yours does not change the hypersensitivity classification. And in the same way, hemolytic disease of the newborn or erythroblastosis fetalis is also a type 2 hypersensitivity reaction. In it, we have maternal IgG against rhesus antigens crossing the placenta to attack fetal cells. Yours or your mother's antibodies attacking circulating red blood cells are still antibodies attacking circulating red blood cells. And by now, you've probably realized a large portion of cytotoxic type 2 hypersensitivity reactions concern blood autoimmunity, autoimmune hemolytic anemia, autoimmune thrombocytopenic purpura, hemolytic disease of the newborn, and ABO incompatibility reaction are great examples. But examples of immunoglobulin cytotoxicity including solid organs also exist. Besides acute rheumatic fever, which we've already mentioned, we have a differential diagnosis for post-streptococcal glomerulonephritis, a disease that also includes damage to the glomerular basement membrane, Goodpasture syndrome. But they differ precisely in mechanism, whereas we've seen that post-streptococcal glomerulonephritis involves immune complex deposition leading to the lumpy-bumpy pattern. In Goodpasture syndrome, we have autoantibodies targeting type 4 collagen, a major component of the basement membrane, in both the kidneys and the lungs. This is reflected in the linear antibody deposits on immunofluorescence. And you know what I'm gonna say? If we have immunoglobulins attacking tissues, this is type 2 cytotoxic hypersensitivity. You want another example of cytotoxic type 2 hypersensitivity? Some time ago I made a video on blistering skin diseases. Well, both pemphigus vulgaris and bullous pemphigoid are caused by autoantibodies against adhesion structures on the skin, desmosomes or hemidesmosomes. And then we have the non-cytotoxic examples of type 2 hypersensitivity. I mentioned Graves' disease, in which stimulating autoantibodies against the TSH receptor mimic the action of TSH on follicular cells. But the opposite can also be true. Instead of stimulating in myasthenia gravis autoantibodies against the acetylcholine receptor, inhibit acetylcholine binding to the receptor and thus cause muscle weakness, acting akin to an antagonist. The same happens in pernicious anemia, in which the antibodies bind the intrinsic factor. No cells are killed, but the intrinsic factor is neutralized, hindering vitamin B12 absorption. Immunoglobulins can be either stimulating or neutralizing, depending on the target and the circumstances. Oh, hold on, you said there is no cell death in pernicious anemia? Well, not because of the antibodies. The immunoglobulins are non-cytotoxic. There is indeed, of course, cell death, but it's mostly cell-mediated. So, you could argue that pernicious anemia is a combined type 2 non-cytotoxic and type 4 hypersensitivity reaction. There is no antibody-mediated cell death. Hence, you are aware that type 1 hypersensitivity is mediated by IgE and involves allergic reactions, and you now know roughly a dozen examples of hypersensitivity mediated by direct IgM or IgG action, type 2 hypersensitivity, both cytotoxic and non-cytotoxic. You also know that type 3 hypersensitivity can be caused by deposition of IgM or IgG immune complexes either against self-antigens, as in systemic lupus erythematosus, or against foreign antigens, such as in post-streptococcal glomerulonephritis or in polyarthritis nodosa. Polyarthritis nodosa is a vasculitis strongly associated with hepatitis B virus infection, HBV for short. Precisely because its most common cause is deposition of immune complexes against HBV antigen in the vessels. So, another example of immune complexes against a foreign antigen causing type 3 hypersensitivity. The same applies to proteins injected in your body as vaccine or serum that may be attacked by our antibodies and form immune complex that will deposit, causing arthritis reaction and serum sickness respectively. Obviously, the fact these diseases exist does not mean they are common. No one is saying every hepatitis B patient has polyarthritis nodosa, for example, just that the mechanisms involve the association. Immune complexes are supposed to be cleared from the blood by the reticuloendothelial system. Having them persist and deposit is the exception, thus why it is studied as a pathological condition. And then we have type 4 hypersensitivity, caused directly by T cells, of which a couple more examples would be Guillain-Barré syndrome, the peripheral demyelination syndrome, and the PPG test or tuberculin test. If you prefer, you can call type 4 hypersensitivity the antibody-independent hypersensitivity. After all, type 1 has IgE, type 2 has IgM and IgG, and even type 3 has immune complexes formed by IgM or IgG plus antigen. It's easy to understand, for example, why the PPG test is a type 4 hypersensitivity. Mycobacteria such as Mycobacterium tuberculosis elicit a cell-mediated immune response. Have you ever seen a granuloma made of immunoglobulins? I haven't. They have epithelioid cells, other macrophages and lymphocytes. It's a cell-based defense. So, when you see granulomas or granulomatous autoimmune diseases, such as Crohn's or temporal arteritis, suspect type 4 hypersensitivity. If you see granulomas, it's a cell-mediated immunity. If it doesn't involve immunoglobulins as the primary mechanism, it's a type 4 hypersensitivity. Well, I hope this has been useful. I tried to explain the diseases in an order that made sense by contrasting them with each other and thus making the mechanisms clearer rather than just listing them by types. I hope this has been a useful approach. Thank you for watching all the way to the end. And since you are here, why not watch my graft rejection mechanisms video, for example? And if you are interested in personal tutoring, check my Instagram. I will keep it updated with these news and offers, and I hope to see you on the next video.